Okay, well, thank you so much. I am Kate Cordell, and I work at the University of Kentucky Center for Innovation Population Health on special projects. I am also Director of Mental Health Data Alliance, which is a consulting firm that I established over a decade ago to support the meaningful use of information and data for children and families in mental health and child welfare and social services. With me, and I'm also co-founder of OPICA as well, and we'll go through that in the disclaimers. With me today, I have Olga and Elizabeth, and I see Elizabeth. Do you want to introduce yourself?
Sure. Good morning, everyone. It's great to see you. I'm Elizabeth Riley. I also work at the University of Kentucky Center for Innovation and Population Health. I'm a clinical psychologist by training, and so I'm really happy to be presenting with Kate and Olga on this work this morning. I think I saw Olga here as well. So Olga, you want to go ahead?
Yes.
Oh, there she is. Yeah, great.
Hello, everyone. My name is Olga. My last name is unpronounceable. I'm from Russia originally. I work for University of Kentucky at Center for Innovation and Population Health, and I'm a statistician by training. Very glad to have you all at our session, and we'll proceed.
Great. Thank you so much. Okay, so without further ado, it looks like we have almost 100 folks on. Thank you, everyone, for attending. Our learning objectives today are to look at the top CAN's actionable items that are most often resolved in a trajectory of resilience. And so we're going to be going through exactly what a trajectory of resilience might be or might look like in this talk, along with some deep dives into the methods. So my apologies in advance to the folks that may be a little, uninterested in the methodological part of it, but we will dive into a little bit of the methods later on. So if you wanted to repeat the study, you could. We're also looking to indicate when a child and youth is on a trajectory of success, and our goal is to distinguish areas of focus for resolution so that we can help prioritize how to help get kids onto the right trajectories of success. And we're specifically looking at two populations. We had originally wanted to look at youth in children with risk for suicide and danger to others. We did end up looking at kids for a population of kids at risk for suicide, but the second population is substance use in this example. So my apologies in advance for those who are more interested in the externalizing danger to others, but that could be a focus for a future talk. And then we have our disclosures. Olga has nothing to disclose, as well as Elizabeth. And for myself, as I mentioned, managing director of my consulting firm, as well as co-founder of OPICA, and assistant professor at the University of Kentucky is my other affiliation. So the learning objectives today, I thought it would be interesting to go over the prior work on the CANs and ANSA. This is my 5th year presenting to TCOM around certain topics and subjects, and I thought it would be interesting to go back and review the other 5 years and what we've covered, because I think I'm hoping that we're continually building on those foundations that we're doing every year. We'll do an introduction to the TCOM data reservoir, which is where the information for this study came from, as well as covering our project goals, background, methods, results, and have a little bit of a discussion and talk about future direction. So I have a history of presenting ideas at the TCOM conferences that are not fully formulated and ready to be published or publishable. So I like to try to seed ideas with folks and see if that instigates other folks to spark new ideas and do some new analysis. And so over the years, I've done a number of those kinds of presentations, and it will be like today. Today will be kind of a not quite fully formulated presentation of methods that we've gotten to this point, and we'd love to have your feedback on next steps or ideas around how to take this to the next level. So because we're a community that has done this in the past, I'm sure that we can do this again today. So I think we've gotten to a really exciting point in our trajectories work, but there's a lot more work to do. So in the past, 2017 was one of the first presentations that I was asked to do, and this was on total actionable items. So it was a supervised random forest and recursive partitioning around total actionable items that included both needs and strengths. And there was a publication that I had around this work. And what this did was it used the cans to look at what were the total actionable items that, when resolved, would result in success in care. So what this is showing in this analysis is when you resolve, or actually what in this particular approach, it's what items are driving total need. But we could also look at what items, when resolved, are related to success in care or resolution of total need. So we can do it either way. So the one I'm showing you actually on the screen is what's driving total actionable items. But we could also say, how would we, if we resolved frustration management, then would that result in a lot of other items also being resolved? But in this dendrogram, just to run through really quick, there were 7,000 kiddos. They had 13 actionable strengths or needs. So those are 2s or 3s on the cans. This was at the initial, I believe. And then if they had frustration management, they had 28 actionable items. So this was looking at what items are associated with higher level of need. So with frustration management being actionable, we saw an average of almost 29 items. If they also had substance use disorder with peer influences actionable, there was an average of 40 needs or strengths to address. And if they also had life functioning for recreational, meaning they were not spending their free time wisely, then there was 45. So this was our highest need group in this example. So looking at combination of frustration management, substance use, and life functioning led to our highest need group. So this is just a way to analyze, use the cans to look at what are the different items that are associated with high needs groups. And this could help you understand better what items from your population you might want to look at or include in identifying, for example, intensity of services or prioritizing care for those populations. So that was in 2017, and I know that Seneca in the following year had done this analysis on, Josh had done this analysis on his population and presented, I think in 2018 or 2019, and that was really neat to see. Some of this work, I provided all the methods to go with this and be happy to provide that again if you were interested in doing this type of analysis. So it was interesting to see folks do this analysis after it was presented. I'm just going to stop and pause to see. I lost my comments area. Okay, there it was. All right, so no comments on that yet. And then I don't know, Olga or Elizabeth, if you have any thoughts on this type of analysis. I know, Olga, you're really you really like doing the recursive partitioning trees as well in a lot of your work.
Yes, I do. One of the possibilities that you can do is obviously not build one tree, but multiple trees. So go something like a random forest approach. Another one is actually the ones that I typically use is called ADA boosting technique. So it's whenever you build lots of very simple models. Instead of a tree, you build what's called a stump. And then unlike random forest, where each single tree that you build have the same amount of say in the final prediction, with those stumps, depending on their predictive performance, they have different amount of say in the final prediction. However, I agree with you; those techniques are very useful, and I find them. I use them a lot with CANS type of data, with either total number of actionable items or per item response.
Oh, that's great. I would look forward to seeing the stump analysis if you ever present.
I would be very happy to share my code with the stump analysis with CANS data. If anyone is interested, please email me. I can provide my email in the group chat, and we can continue this conversation.
Yeah, that'd be great. Okay, so that was 2017. Thanks, and Olga. And I will say that usually what in this publication you'll see, if you grab the publication, you can see the methods there too. I did do a random forest first and only pulled the top items from the random forest to build out the recursive partitioning, so as to reduce the overfitting that commonly happens with this type of dendrogram.
Yeah, makes sense.
And then the next year in 2018, I was really hammering home on this ever actionable idea. And so this was one of the slides from that year where we looked at initial, ever, and last, or initial, ever, and discharge. Meaning if we're going to look at total number of actionable items or total score, either way, if you're going to look at a total sum of the ratings, or you're going to look at a total count of actionable items. And if you only look at initial and last, what you miss is the middle. So you're missing all the change in the middle. And with the CANs in particular, and the ANZA as well as probably the FAST, at the initial assessment, we don't know everything about the family and the child, and it is anticipated that you would learn more during care, and so that's normal. So to not account for that, or to put negative pressure on a system for finding more things wouldn't be helpful to the family. So we do expect every time we run a CANS, it might look something like this right here. Would be perfect. Would be the hockey stick. So you'd start out with hopefully a majority. You'd get a couple more, maybe up to 25% more items actionable, but at the end you'd have few. So this would be the perfect CANS kind of initial, and then ever actionable combines the max score of every item, and then you look at how many of those were actionable over the whole period. So you only need 2 assessments to get an ever actionable, but that would be higher than the first or the last, because there'd be some things that were actionable on the first that weren't on the last, and some that were on the last that weren't on the first, and you'd still get that hockey stick. So with 2 assessments, you can get an initial, an ever, and a last, and that's going to help you understand what was the total need ever in the entire episode of care versus the first and the last. What we commonly see, however, is this BAT. This is the most typical, I think, pattern of initial, ever, last that folks see. They'll see it go from 12 actionable items to 11. It'll say, oh, we addressed 1 item, but that's not correct. You've actually addressed, in this case, 3. But because we didn't look at ever, we didn't see that, right? So that was the whole thing we talked about in 2018, was the importance of looking at what was ever actionable to see how many needs were addressed or strengths were built, instead of going from first to last. Going first to last is highly discouraged because it is not an accurate representation of what happened in an episode of care. Any thoughts on that one? Just curious. I've seen a lot of ever actionable presentations since then, and I think that's great, and I'd love to see that continue as well. And then also in 2018, I did this cluster analysis, and this was the result of that. And again, this was like just kind of throwing it out and saying, if we do these kinds of analyses and get these clusters, how can we make sense out of them? And just as an idea, throwing it out. And so I had 16 clusters that I had identified with, various different kinds of story maps, basically stories that went with these clusters, and then identified some of the top items associated with the clusters and whether the kiddos that were in this cluster were above or below average rating along physical domestic abuse, adjustment to trauma, bio-caregiver relationship. And so it came up with this kind of pattern. You can see, cluster 1 is kind of the low need group, and cluster 2 is physical and domestic abuse, and so forth. So we've got these different clusters, but 16 clusters was a lot, and it was kind of overwhelming. And Stephen Shimshock has since then come up with wonderful methodologies to do a latent class analysis and further clustering. So this methodology just presented, but didn't continue down a road on too far, because with the 16 clusters, it did feel a little bit overwhelming to the group.
Hey, Kate, just real quick. So we've got a question in the chat about, is it legitimate to ditch the first assessment? I know I've got some thoughts on that, but I wanted to see what you had to say about that as well. It's a great question.
Yes, and I wanted to contribute to that as well.
Yeah, I mean, I don't think you want to ditch the first assessment. I think that the first assessment is useful in many, many ways. One way is comparing the first assessment to your ever actionable is going to identify how thorough you were on that first assessment, right? So if a lot of times that first assessment may be a screen and it may not be very thorough, and you're not going to get to the ever until you look at the first, second, and maybe even the third, because you're building a trusting relationship with that person in care or the family over time, and they're revealing more to you, and you're building that story out over 2 or 3 assessments. But knowing what they were wanting to reveal or were open to reveal on the first assessment is super informative when we look at ever. So I would say you absolutely want to keep the first assessment. You absolutely do not want to use the first assessment as your baseline. So I would say you absolutely do not want to go and look at what was the change from first assessment to last assessment. That's not going to be an accurate representation of the progress in care.
I think also from a systems perspective, I mean, if you're looking at this data in its aggregate form, I think the first assessment can be really helpful, thinking through, what kinds of things are the clinicians in your system identifying first? What are they not identifying first? And is that, how much of that is, to Kate's point, the relationship building that you're building with the client? How much of it is potentially a training issue of really wanting clinicians to start identifying particular items earlier? So completely agree with what Kate was saying, that it's definitely, important to have that first assessment. And I think you can learn a lot from it, both about your clients and about the system as well.
So I maybe thought about your question from a little bit different perspective. Whenever I saw your question in the chat, I immediately thought that maybe you want to get rid of the initial assessment because you want to make sure that the baseline observations for each single one of your subjects are exactly the same. So hence, everybody start with the same baseline levels. How can you do that? Because obviously, everybody's initial CANS assessments are not the same. I just send a link to the chat with the publications that just been accepted, and we have another one on the way where Kate and Elizabeth, both of us, are co-authors, where we talk about the idea of the rate of resolving items. So for instance, whenever at the initial assessment, whichever it is, we say that from the very beginning, all subjects have 0 items that they resolved. And then we keep on saying, as the subjects participates in the treatment, some items become actionable, some items become non-actionable, and we developed an algorithm to try to keep track of that over time. So it's very similar to the idea that Kate was presenting here with a hockey stick, but a little bit expanded. And in a way, we are starting with the baseline measurements that are the same for each single subject. So if that was the reason why you wanted to ditch the initial assessment, maybe you can do that, basically saying that everybody's starting at level 0, but then you need to build up from that, and the initial assessment actually contributes to that building up. So if you're interested in that method, please follow the link and look at what we've done.
Yeah, and I would also caution, if you do throw out the initial assessment and you say you use the second assessment, there will be things that were likely an issue on the first assessment that were quickly resolved. And, some things like transportation, which Olga has a paper on as well, may get resolved very quickly if we're able to, get bus passes or gas cards or whatever it is that's needed and resolve that pretty quickly. And you're never going to see that if you threw out that first assessment when that was the issue there, but on the second it wasn't. So I would suggest never throwing out the first assessment. You need to pull forward what there was in that first assessment. And if you wanted to look at the sub-ever, meaning what was ever actionable on the first, second, and third assessment to the last, you could do that. But but yeah, and then along with Olga's methodology as well as an option. Okay. Oh yeah, and someone just said that Dr. Lyons just said people change things quickly as well. So exactly. So perfect. Great. All right. So that was that. Okay, and then in 2019, oh, there it is. It was in 2019, we talked about needs, strengths, and then having the underlying exposures and past behaviors as their only, as a separate kind of count, so that we were kind of isolating more of the needs that could change from the needs that wouldn't change. So that was kind of what we talked about in 2019, was just really making sure that when you're looking at your actionable needs and you're looking at change over time, that you're separating out those traumatic experiences into their own group, because we don't expect to undo something that's happened to somebody. And so we really just kind of emphasized that in 2019, was just make sure when you're looking at change, if you're looking at proportion of change, if you're holding people to a percentage of change in a jurisdiction, that you're not lumping in trauma in there, because we can't change trauma, right? We can change adjustment to trauma, but we can't change those ACEs. Also, not to lump in anything that is past behavior that wouldn't change. So if the question were worded in such a way that it said, did this ever happen? Then you don't want to lump that into your needs to be addressed, right? So just being a little bit more thoughtful when you look at change over time, that you're identifying your past behaviors that don't change and your exposures that don't change, kind of in a separate bar. And then again, this is just the initial Everlast kind of display, rather than in the hockey sticks, just in bars. And noticing that the underlying, we don't expect those to change, those exposures and past behaviors. Also in 2019, we talked about this concept of a story map. And so the story map being that we could present the information from the cans in a way that was kind of a story that laid out the needs together that were actionable, the strengths to build and use together, and then the underlying items that we just talked about, maybe in the periphery, as well as the background needs in the periphery. So now if we reorganize the cans after it's been rated into this story map, what we get is a really quick view of how to focus and what to consider during that care planning. So if you look at this story, and this is based on a true story of Maria, Maria experienced emotional abuse, witnessed family violence and physical abuse, and these are her underlying areas over here we want to keep in mind. We're not expecting those to change. And then here we're focusing on her affect dysregulation or depression. Here's where we're focusing. And then here are the strengths that we have 3 we're building, and we have a number we're using. So we're keeping that in mind there. And then all the ones in the needs are over here. So these are areas that we're keeping an eye on that may raise to the level of being actionable items. But currently we're just keeping an eye on. There is a little bit of a sleep issue. There is a little bit of anger, anxiety, but not raised to the level that we're intervening at this point. And then you can track that over time. So here's how it might change. So here was the first assessment. And this was, based on a true story. What happened on the second assessment? Well, if we thought about, if we looked at the second assessment, we might think, oh, things are getting worse, but it's not necessarily the case. Maybe what we're adding here, and it really depends on the types of items that are coming up, what maybe the things we're adding here is because we've built a better relationship with Maria, and she's telling us about, what she's really feeling and what she's really experiencing. And then over time, at year 1, there was a lot that was resolved. And then 1.5 years, a lot more resolved. 2 years, maybe something came back up. And I think that's normal. 2.5 years, more resolution. And then 3 years of planned discharge. So at the end of her story map, she did still have a few things that were actionable related to her family, caregiving, and living situation. And like I said, this is a true story from the data based on a true story. And so this is like a teenager who was in care for 3 years. And then she resolved many of the areas personally, but still had some family areas that were actionable at the end of care. So just a different way to kind of look at the cans in a story map. So that's what we talked about in 2019. And then let's see, was there any comments on that? Oh, we have a couple comments there. So probably not the story map. I think these came in before. But Allison says that in Vermont, she found certain items were systematically underreported at the first can, such as sleep, for example, would often pop up in the second cans, as well as spirituality, strength. That were informed by the child welfare and main informant. Caregiver needs were well known and child needs were underreported. These discoveries helped us identify areas in need of improvement at initial assessment. Thank you, Allison, and feel free to unmute yourself if you want to add to that.
I think you covered it, Kate. We found it really helpful in improving quality improvement for initial assessment and also just habits of providers, right? I know myself, I ignored certain things and then used the cans to improve the comprehensiveness of my assessments.
Awesome. Thank you so much. And then Dr. Lyons says, I think others are finding similarly that certain needs are harder to uncover than others that may have implications of how we think about initial engagement process. And feel free to unmute yourself, Dr. Lyons, if you'd like to expound on that.
No, that's all I wanted to say. So I think that identified, it's really important data from a variety of different. It may be that it's impossible to uncover things too quickly, which is why the analysis should always have the ever actionable, but it may also be quality improvement data about what we're not very good at uncovering in the initial story. And maybe there's other ways that we can approach it that help people. Like sleep to me seems like something that you could focus on and get regularly early. Caregiver needs, I'm not so sure, right? Because you have to build trust and so forth. So I think it might depend the meaning of that.
Excellent. And then Olga, you
said I had nothing to say, but I can never stop.
I know, right? No, it's good. Well,
I
don't want to be the one talking about them. I'd love for this to be a conversation. I hope that people are finding kind of this walk down memory lane useful, just in case we have new folks to the community, or or maybe they hadn't heard about it. So these are kind of some of the ideas I thought I'd just throw back out there and reseed the garden, right?
So I think it's important to sort of point out for folks too, with 131 participants, that there are no silly questions. It's very likely that if you have a question, someone else also has that question. So I want to implore you all to sort of engage and ask those questions, either in the chat box or by unmuting yourself and starting your video.
Awesome. Well, thank you very much, Brandon. Olga, did you want to say anything?
No, it's basically the same as Dr. Lyons just said, that, well, obviously I don't work with the clients, but I work with data quite a bit, and I do see that typically certain item ratings tend to go up. Hence, you showed us the hockey stick, and it may be underreported an issue, but it also may be just the fact that you need to build trust with your client, and then you uncover certain things about your client. So,
Yeah, keeping an eye on what's more commonly discovered, meaning it wasn't on the first assessment, but it was somewhere ever. So when you go from first to ever, those are your discovered. So keeping an eye on those is super important to figure out, systematically, what are we missing in the beginning?
Hi, I'm sorry, I'm driving, so I have my my video off. I'm on the West Coast, so it's early morning for me. But I understand, I'm hearing it from a clinician's perspective, and I'm from child welfare. So the engagement and point in time for our child welfare workers in LA County who are conducting the initial cans, we have our emergency response social workers conducting the initial cans, and their engagement is a little bit different when they are trying to assess and who else is on the team at that point in time when a worker is going out in an emergency response situation or barely working with the family. The engagement's a little bit different. The collaterals are a little bit different. We may not have clinicians on, and it's very quick. so we sometimes underrate the items, and sometimes we get the opposite. We overrate the items because we are meeting these families in crisis mode, and they kind of give us, spew out what's happening, what's the major crisis at that point in time. And so we may overrate, and we might kind of dismiss some of the other actionable items because we're just focusing on what's happening this day. We move really quickly. So I'm starting to find that when I'm comparing the initial cans from a clinician that happens to be on board, like a MAT assessor in LA County, versus the initial cans that an ER worker is doing before it's solidified. We do the one cans, one child. So they're doing it, we're doing it, and we're solidifying it at the end. It's very different, and obviously from different perspectives. So we have to have this conversation like, well, how did you get this? Or how did you come up with this? And, oh, well, I know this caregiver. I'm working with them. I've worked with them before. Oh, well, I don't know this caregiver. So the engagement process is, and just who are we speaking with, and how much time have we had before? It really does affect how we underrate or overrate. And that's what I'm seeing when I'm kind of evaluating both cans.
Thank you, Crystal. This reminds me of several of Dr. Lyons' stories, and I don't know if Dr. Lyons you want to jump in, but to me it reminds me of how you talk about, well, first of all, the whole purpose of a community metric. I think you just described it, and then second of all, that catastrophizing that you always talk about, Dr. Lyons.
Yeah, I think there's a couple things going on with that. Thank you, Crystal. I think your observation is really central to how this should work. And from an analytic perspective, I think it's a very good reminder that you're measuring the story. That's what you're measuring when you're using the cans. It's a measure of how people perceive what they perceive the story to be. And as we talk to each other, the story gets crystallized, it gets better, because when you have more than one storyteller, you have a fuller view of the circumstances of that child and family's life, and you can have a more fulsome conversation. So I think understanding that underlying premise of the approach is really important as you understand these analyses, and the fact that if we talk to each other and we collaborate with each other, we get better assessments, we get better results. I think one of the things that's funny, it's sort of gone away. It used to be when we first started doing this work, is people will say, well, two different people do the cans, they get different results, and somehow that's a characteristic of the cans. And I'd always say, no, that's a characteristic of how the system actually works. The cans is surfacing what's wrong with our system, is that we have these different people who are just operating in the vacuum of their own little space, and they're not talking to each other. And of course, they see things differently because any two people see things differently. So there's a real opportunity here of using this as a common language platform to create a recognition of that kind of complexity. So that's cool.
Thank you. Yeah, I mean, when it comes to the story mapping, what I think is, and you can tell me if I'm wrong, but what I think is, when you're working with folks, you're building that story in your mind, right? It's happening. You're thinking, oh, this family has, this set of experiences or ACEs, and they have this set of resilience factors, and there's this set of needs, and it's building in your mind. And the next time that family walks in, their story. That story map is built in your mind. You don't need necessarily the cans or the story map that's on the screen to tell you that, but it may help to have a reminder of it, right? Or it may help your new people to the team quickly see what's going on and what has gone on, what were the past needs, what were the current needs. So it hopefully is almost, the cans is like taking what is built in your mind already, putting it on paper, and then helping you share and communicate that across the team. So yeah, it is surfacing, surfacing what is going on in real life as close as you can get with that kind of broad, holistic view of whole person, whole family care. So then in 2019, also we talked about, and this, I think this is a super interesting kind of little analytical technique, and you may get something slightly different with different populations, but what this does is it says which items cluster together. So when you think of cluster analysis, often you're thinking of clustering people together. Well, if you kind of turn that on its side, you could cluster items together. So in my population, if I'm often seeing, for example, runaway behavior, what other item is most closely associated with running behavior? Oh, well, it's school attendance and it's substance use and it's delinquency. Well, that makes a whole lot of sense, right? So in your population, you can see if I'm seeing an item, what item is most often commonly associated with that item coming up at the same time, so that if I find that there's a school behavior 2 or 3, I really want to make sure that I'm digging in on school achievement, right? Or if I find that there's caregiver safety, I really want to dig in on caregiver residential stability. And so it's helping you kind of identify which items are commonly found together so that you can make sure that you're digging in on those areas where maybe only one of that closely associated item is showing. So this is a fun little way of just looking at that correlation.
Just one thing that fascinates me with correlation among all of the items, and I'm not sure whether there are many statisticians in this group, but all of the items only have positive correlations. There is not a single 2 pairs of items that are negatively correlated. And quite frankly, I'm not sure what to do about it. There are some methods in numerical ecology whenever we are talking about, like, for instance, species abundance, and their correlations are typically positive. A presence of one species possibly associated with the presence of another species. I don't know. It was always fascinating to me, well, at least in the last couple of months, that all of the correlations are only positive, and whether we can do anything about that or not. But that's just a thought.
Need predicts need.
Yeah, but it's always like that, and it's very unique to that type of data. So can we somehow take advantage of that or not, other than just observing that it's always positive? I'm not sure.
So I think we had another couple comments. Program that organize the items into these clusters. And I'm not sure, I don't know. Oop. Am I still on?
Can I make a quick comment on Olga's point? Because I think that's a really interesting point. I also think it's why it turns out that you can actually build psychometric measurement on the back end of a CANS, is because you do have these inter-item correlation coefficients that allow you to combine items because they are in fact related to each other. So for those of you who like that particular approach to analysis, there's your justification that they are actually related to each other. There is some dimensionality of needs and strengths that captures this kind of things are going well or things are not going well. And so that allows you to do that. Now, we did do some scaling that if you want to have a total score, you can't really put the needs and the strengths together because they are rather different. They don't really scale well on like an item response model or something like that. But you can have a needs score and you can have a strength score if you want. You need to separate caregiver too because it's just different. But it is interesting, Olga. I think there's got to be ways to capitalize on it.
Yeah, so then we talked about, and we'll get into the analysis here. We've got a full 2 hours, so I thought it would be fun to go over a lot of different kind of techniques, and then we'll get into the technique that we're talking about today. But I was just saying that go to Amanda's talk on Thursday to hear more about applying factor analysis in her population in New Jersey and how they use that. But what we did in 2019 was look at doing a factor analysis and just kind of taking a quick look in an ordinal way at the factors that were produced there. And then also in 2020, working with Vanderbilt University, used the FAST to reverse engineer a decision tree to identify how they were making risk analysis for kids being placed in or out of home. And I don't know if Kathy Gracie is on. That might be able to talk a little bit more to that. I thought I saw her. No, I guess not. Anyway, so we presented on that last year, and I don't think that did get recorded, but this was using another way you could take the CANs or the ANZA and really kind of look at how your decisions are being made. So this would be a way to reverse engineer what is systematically happening. And if you wanted to use this to reverse engineer how you were making decisions, you could add in age, you could add in race, you could add in other demographics and see if those actually play a role in that decision process, in addition to the items in the faster the can. So just throwing that out there, that's another method. And there's a report around there if you want to see the method we used to map out decision processes in this way. And then in 2020, we presented also the patterns and priorities dashboard. So this is another dendrogram that I mentioned earlier. So the dendrogram that I showed in the beginning identified what items, when actionable, were drivers or associated with higher levels of need overall. And this one looks at what items, when resolved, are drivers of success in care. So it's that reverse I was talking about. So these dendrograms here that are built, say if you build more than one strength, you go this way, which is positive, you have better chance of success. If you don't build at least, two strengths or more, if you build one or less strength, there's a 0% chance of success in care with this particular population. And then it says if you build 2 strengths or more, plus you address anger control, plus you address recreation for this particular population, that's your best chance of success in care. And success in care is defined as resolving a certain percentage of total overall needs in this example. But success in care could be anything. You could define success in care as positive disposition, having met their goals, a stable placement, whatever that success factor is. You can look at which CANS items are resolved and associated with success. And this is going to lead into kind of more of the thought process that we're using today. And I lost my comments and I fell off here.
All right, so
go ahead.
Your chat box should be at the top of your screen. The screen that there's a toolbar for Zoom.
I got it.
There you go.
Yep, I got it. Thank you. And Amanda was happy for the shout out. So Amanda Thompson, yes, go to her talk to see more about some of those analyses. So then, and another shout out to Amanda. This is what we presented last year, and Amanda's repeating this in her talk a little bit in a manual process, but this was now applying that factor analysis and finding kids who look like the kid that we're trying to serve. So it's called Care Compare. And this approach is doing that factor analysis, saying, here's the story map that we talked about. Here's the factors associated with the story map, and we're going to give that a factor score. Who's got a similar score on all those different factors as the person I'm trying to serve? And what services did we provide that successfully resolved the need for that person? Can we take that information as a starting point for the person we're serving who has a similar story map? So again, if we think about that story map in the CANs, we're trying to find someone who has a very similar profile of CANs items and trauma and strengths to build and strengths present as the person we're trying to serve. And then we're going to evaluate what types of services, what types of care, what supports, what tools, what tactics, what technology helped that other person reach success. And so that's what we talked about last year as well. And also this year, for the Italy TCOM Italy talk, we talked about AI for authentic assessments, and there is a paper published on this. But basically, the long and the short of it is that looking at again, that story map, looking at the variable correlations, and looking at the patterns that exist. So when people have a story, it's not a random combination of CANS items. It is a combination of CANS items that are closely associated usually with parts of that story. So there's common threads around patterns of CANS items. And if we look at those patterns of CANS items, can we identify when there are some areas of actual need that maybe we overlooked that should have been marked? And so it's looking at the authenticity of the assessment to make sure that we're capturing the full story, because there'll be holes in that story that can be identified with AI. And so that was what that publication was about, finding how often, and this is a good way to look at maybe your data quality. So if you get a lot of randomness in these stories that doesn't make a lot of sense, then the AI can pick that out and say, the data quality here isn't as high as it could be. And then when you have a higher data quality, it can then pick out gaps or holes in people's stories that maybe you want to dig in on. So for example, if there's physical abuse and no emotional abuse, but there's neglect and some other things, and emotional abuse isn't there, that may be a hole in the story where maybe emotional abuse was there, but it was just overlooked, it wasn't marked. Okay. All right. And then also this year, we talked about the ability to do assessments as a team so that everybody has it on their phone. And this was in the TCOM Italy. So having the assessment available for everybody to know and rate together as a team is now, is possible. So that assessment's anywhere possibility. And then we talked about skill sketches this year as well. And skill sketches are perhaps a fun way to help youth identify their strengths and skills over time. And we have these free to download if you want. There's a bunch of other animals. There's owls and cats and unicorns. But basically the idea is you have a piece of, you have an animal like this, and you've got lines where you identify the eyes are for strength and the nose is for, I don't know, playing the trumpet, whatever it is that you want to assign to it. And then you color it according to whether it's a strength to build, a strength that's building, a strength present, or a centerpiece strength. And then the idea would be assessment 1, you have a lot to build, but hopefully by later in the assessment, you're up to the blue and purple. And so you can color, you can have the kiddo or adult, doesn't really matter, could be an ANZA, color that as a way to kind of track their skills over time and their strengths. So that's just another thing we talked about this year. And those are little worksheets. Those are with coloring crayons, obviously. Oh, also at 2021, we will be talking about this. So then we will be talking about taking the cans and putting them in family reports. And this was a project that was done with California Department of Social Services originally through a stakeholder group to see how could we present the cans in a way that was family friendly. And then FaithBridge will be presenting on how that's working for them. So they've implemented that with their families, their foster families. And so they'll be presenting on that and some other aspects on Thursday. We'll be presenting that together. So a little plug for my other presentation. Okay, and there's my plug for Amanda Thompson for Thursday, in case you want to know the time for that one. It is Thursday, and so it's Thursday at 3 for the family reports, and Thursday at 4:15 for Amanda's New Jersey talk. Okay. So that was the walk down memory lane of the prior presentations. And so just a summary, we talked about total actionable items, ever actionable story maps, some cluster analysis, which now Stephen Shimshock has as, I'm totally blanking now again on his approach. Somebody help me. But Stephen has the cluster analysis now. So if you have questions on that, you can ask him.
Latent class analysis.
Thank you. Latent class analysis. I totally blanked on cluster and class. The factor analysis, the reverse engineering of decision patterns, patterns and priorities of success versus patterns and priorities of need. And then care compare, authentic assessments, assessments anywhere, skill sketches, family reports, and then success focused care planning in progress with Amanda's group. Okay, now on to, and I thought when I was building this talk, I thought it was helpful to go over that because I think a lot of the same concepts build into what today's Trajectory of Recovery and Resilience is about. And it's helpful to think about those concepts when we're building into looking at patterns of change over time for success in care. But before I get into that, and I don't know, Brian, if you are able to take the reins on this, but I'd like to introduce Brian to talk a little bit about the TCOM data reservoir.
Sure, I can say a few words. I don't think it'll be a problem.
Okay.
So the TCOM data reservoir is essentially a database of the data that folks that we partner with around the world. They share their data with us, and the data goes into a database that we've dubbed the TCOM Data Reservoir. And this database allows us to introduce all sorts of advanced statistical and machine learning applications that are important to have a large sample size for. So the database is, as it says, the state-of-the-art HIPAA and FERPA secure data reservoir. And as of right now, there are several million stories housed within the secure data reservoir. And
That's me.
So we're able to use a big data approach since we have this many observations, these number of cans assessments that help us answer all sorts of questions that wouldn't be possible otherwise.
Okay. And I'm going to fix the HIPAA spelled wrong. So I was just working on fixing that. But okay, go ahead.
Sure. So the data that we receive from any of the partners that partner with us contain some personal information such as demographics and basic locations and additional program and episode information. And what we're able to do is transform what we call our raw data into data that is research ready, that is de-identified and able to be published. And yeah, a variety of statistical and visualization techniques are used to be able to answer questions that wouldn't be possible otherwise without such a large sample size.
Great. Thanks, Brian. And a shout out to Brian as well for doing a lot of the analytical work on the research or the results you'll see today, excuse me. But yeah, I think that, maybe, I think Dr. Lyons could probably say a few words here too. Oops, resume slideshow. But I think it's a great opportunity where folks can donate de-identified data, and we can all learn from what the patterns are across different jurisdictions, different populations. And I think what we're going to find is some commonalities. Surely there'll be differences because the populations that have served have different are targeted for different needs, and certainly we'll see differences. But when it comes down to it, my feeling is people are people, and there's going to be commonalities in their stories because that's just the way it is across different folks, right? But I don't know, Dr. Lyons, if you want to say something more about the data reservoir.
Yeah, I do agree with you that people are people, and so what we find, I don't know, for those of you who know, I aspire to speak only song lyrics for an entire day, but people are people is in fact a song lyric. But anyway, a couple things. So one is that what we're finding is that actually, particularly with kids are the same all over the world. The kids in Singapore are not that different than the kids in Baltimore than the kids in Milano. It's what's different is the systems and how the systems respond to them, and what's different is the culture. So, and that actually then flavors how we understand data. But I think basically to get to the reservoir specifically, we ask a lot of people to spend a lot of time collecting this information. So I kind of feel I've spent, most of the last, I hate to say, 30 some years convincing people to collect this data. I think it's our responsibility to fully use that information because there's a lot of sweat equity that goes into the process of asking families to tell their stories, asking people to tell their stories, putting it into databases, putting it into treatment plans and so forth. So I honestly think we have a duty to try to use that information. The other piece of it is that for the last 70 years, we've based a large number of policy decisions based on administrative databases that had very little information about the people we served, but a hell of a lot of information about what we did with them. And most policy in most countries is based on the analysis of claims data, the analysis of service use data. So is it any wonder that our focus is on access and on those kinds of things? Because we've never been able to build an infrastructure that allows us to actually look at impact. That is now different. You all, and all of your good work, and all the people in the larger TCOM community have in fact build an infrastructure that can, in fact, be used to see whether or not a system based on the best interest of people might actually be a different system than one based on who gets the money to spend time with people. My sincere belief is that it'll be a radically different system. And I think it's incumbent upon us to see whether or not that's true or not, to use the information that people have so willingly shared to try and see whether we can create systems that care, that systems that are driven by the best interest of the people we serve as represented by their stories. So that's my elevator speech about the reservoir. So that's why we're doing it. And that's why we're not charging anybody to participate in it, because we think it's the right thing to do.
Thank you, Dr. Lyons. Yes. And so the analysis you'll see today is, kind of the first out of the data reservoir. Apologize if there's other uses that have been done, but one of the first uses of the data reservoir data. And I think it's pretty exciting to see, the data being used in this way, and I'd be happy to hear your feedback on how you think we should move forward and build out, that knowledge base. But one of the things that we can do with the data reservoir and what we're trying to do today is look at trajectories over time. So what does recovery and resilience look like? A lot of times when we do analysis, we'll look at who's going to fail, who failed, who cost the most, who went back into care, who recidivated, and so this is kind of taking a little bit of a different look at it and saying who succeeded and what can we learn from the people who succeeded? What can we learn about what we did in a successful implementation of our program for particular kids and youth? And there's just a paper here to show other research that has done work around trajectory of recovery for PTSD. And so taking kind of some inspiration from that, can we look at trajectories of recovery with the CANs? So that's just my little inspiration piece for today's work. So this project in particular is to perform an exploratory analysis at this point. So this is, like I said earlier, this is not work that is publishable. This is not work, that is finalized. This is work that is being presented here for feedback and for thoughts on next steps. So it's an exploratory analysis at this point, but we want to see if we can detect longitudinal patterns of resolution of CANs in focal populations. And so we picked two populations that had behaviors of interest, that, like high-risk behaviors, high-need behaviors that we would want to resolve, importantly resolve to reduce, poor outcomes, right? So suicide risk being one population. So we pulled every kiddo that had suicide risk on their first assessment. So looked at only their first assessment for that purpose, because that'd be something hopefully we would know upfront and part of the reason they came into care. And so that was one of their primary needs in entering care, was a 2 or 3 for suicide risk, and that was population 1. And population 2 had a substance use as a 2 or 3 as on their first assessment. So we pulled from the data set we had those two groups, and there were about 1,000 kids in each of those populations, and I'll show you the numbers in just a minute. But the main question was, what CANs items resolve before others in a trajectory of recovery and resilience? So, but what we're looking for is, and so back in the beginning, when we were looking at what CANs items when present drive a lot of need, now we're looking at what CANs items when resolved drive a lot of success. And then what order does that happen in? So do you need to resolve one item before you can resolve the next? And so do you need to resolve depression before you resolve substance use? Or do you need to resolve substance use before you resolve depression? So that's the kind of thinking that we're looking at. And then can we use this information to prioritize our approach to care so that if we see that story map of a person and we know that you must resolve this before this is going to change or be resolved, then we can prioritize one area over another in our care plan. And that's kind of the practical applicability of the approach, the hoped approach. So basically, this is my graphical representation that when one thing resolves, we're hoping that it kind of opens the floodgates or opens the door for other things to resolve. So if you resolve substance use, it's going to open the door for that person to resolve the relationships with the family members that maybe have been hurt over time because of that substance use, right? So if there's that substance use there, you kind of have to resolve that first before you can open the door to those relationships. So that's the idea there, is what is the order of resolution? Can we use the CANs, the ANZA, and the FAST to look at and begin to look at that order? And I would love to pass it on to Elizabeth to talk a little bit about the background for these two groups.
Sure. Thanks so much, Kate. So we just wanted to give a little bit of a brief background on both the suicide risk, why we chose those items, suicide risk and substance use. And so there is a large and increasing need actually to better understand both suicide risk and then also this anxiety and depression trends in children and youth specifically. There's actually just some research that came out demonstrating that, while suicide and depression rates for children were relatively stable in the early 2000s, so 2000, 2007, 2008. They were relatively stable during that period, but they were increasing pretty substantially between 2007 and 2018 was when this data was published. And so I think that really speaks to not just that there's already a high need, but that need is increasing. I mean, we can certainly talk about whether that's an issue of detection, whether that's an issue of increased prevalence, but regardless, I mean, the need is certainly increasing both with depression, anxiety, and then also with suicide rates as well, and particularly adolescents. So go ahead, Kate.
Okay.
So as you can see here, suicide was the second leading cause of death among adolescents in 2019, and that's a trend that's continued over the last decade and something that is not anticipated to change. So there was certainly, interestingly and sadly, the suicide rates and percentages of children who are considering ending their own lives is getting younger and younger as we see these trends progressing over time. And I think that we've seen that clinically and across the nation. There's certainly a lot of variability state to state. So I think that'll be interesting because we have such a large partnership, which is so exciting. We really are nationwide. To see what this looks like state to state will be really interesting. There's some states that saw just a small bump in suicide rates, which is still concerning, of course, but other states that saw nearly a doubling in their youth and adolescent suicide rates over the last decade. So I think that's really pertinent to this as well. And the other piece of this is that we're still learning a lot about what suicide and depression look like during the pandemic. That's something that the data is emerging on that, about what suicide rates look like, what suicidal ideation look like. There was a concern, at least at the beginning of the pandemic, that there was going to be a big spike in suicide rates, particularly among children and adolescents. But now the more recent thinking is that as children are going back to school, as they're getting a little bit less supervision, that might be a concern as well.
Yeah, thanks, Elizabeth. I'll move to the next slide, but I just wanted to comment, when I was looking around for data for suicide rates during the pandemic, there is just very little data out there to look at. And I can't believe in today's day and age that we don't have that in real time. It's just crazy. So then I was listening to a podcast around why don't we have suicide rates in real time? And there's this whole political, coroners are politically appointed and there's pressure on them to say something is or is not a suicide by the, whoever's in power. This it's part of the reason we don't have real-time data, because it has to be washed, scrubbed for political purposes, was what the podcast was saying. I mean, this is unscientific, comment, but I was just amazed to find out that was playing a role.
It's pretty staggering. And I think that at least what I have talked with some people who work more in this field about is that for a lot of coroners, for those political reasons, if there's a way to classify particularly a youth, child, or adolescent death as not a suicide, that will be the reason that's chosen. So classifying a death as a suicide is almost always a last resort if there can be nothing else that people can point to. And so I think that when we think about rates of suicide, particularly rates of suicide that are increasing increasing despite of the pressures for them not to show that data or not to, have that data come out in the exact way. I think it's important to consider that these rates are probably underrepresentations, particularly for younger children, where suicidal ideation and suicidal behavior is not well understood in these younger kids.
Yeah. Okay. Yeah. Thanks. I just want to add a little commentary on that.
Yeah.
And then substance use. Yeah.
And then substance use. So substance use is our other population of interest and our other area of interest for this particular project. And so again, there's a lot of data to demonstrate that substance use is likely increasing over the last decade or so, over the last couple of decades, but particularly a spike in the last decade, and that those rates we don't expect those trends to decrease or to change a whole lot. So we would expect to continue to see an increasing trend in rates of substance use in children and adolescents. Same kind of trends with depression and anxiety and suicidal behavior, that substance use among children and youth is getting younger. The nature of substance use is changing a little bit, but I think the robust finding is that it is increasing. And I think the other piece of why we're so interested in substance use among adolescents is not just that, it's not going to be groundbreaking to say that substance use in adolescence is bad, but it's also known that, roughly 80% of adults that experience a substance use disorder, it started in childhood, it started in adolescence. And so I think that the real point here, the real idea that we're trying to understand is how to get at this early intervention for children and youth who are experiencing substance use disorders. There's enough problems associated with substance use among children and adolescents, and they just continue and get worse as we go into adulthood. So really this idea of trying to figure out what needs to be resolved in order to resolve or make some dent in substance use is really crucial for the long-term health of these folks. We know that children and youth who are served in child welfare populations and in public and mental and behavioral health systems across the country, it's been well established that those folks have an increased risk for developing substance use issues compared to kids who are not served in those public systems. So I think there's this dynamic of being a really special population and being a population where understanding substance use and the development and the trajectory of both substance use resolution and the development of substance use itself in this population is really crucial.
Thank you. Thanks, Elizabeth.
Yeah.
Awesome. So that kind of gives us a little background on the two populations we chose of interest. And we selected two because we wanted to see how the method would apply against different areas of focal need. So again, I said there were about 1,000 kiddos in population 1, also 1,000 in 2. Population 2. So that was the first step. So now I'm going to run through the methods, and this is where it may get a little bit into the weeds. So I wanted to warn folks up front. But we'll hopefully get to the point where we have something that's clinically relevant to chat about in a few minutes. So the first step then, what I did was, or what we did was limit the data set to only kids that had more than one assessment. Because if there wasn't a reassessment, it was hard to look at trajectory of change over time. It was impossible because there was no trajectory. So first limited to the kiddos had to have 2 or more assessments. And then here's the ages of the two populations. So you can see in the suicide risk, as Elizabeth mentioned, there were some really younger kids in there, which was quite concerning. And then in the substance use, it was a little bit of an older population. It didn't start really until maybe age 12. And then there were no 18-year-olds. It was 17 and younger. So it's 18 is 0 for both of those. So there's not 18-year-olds, but there are younger kiddos in there. Or if there are, they just turned 18. So they may have been 17 and turned 18. So this was a child welfare population as well. So that's something else to know. These are kids that are placed out of home. So you'll see that in the analysis that those items will be coming up. Okay, and so here's an example of the raw data. So I'm going to walk you through exactly what the data looks like for each step. So this is going to be your raw data, in which case, let me orient you. Josh has 6 different assessments. So he has 1, 2, 3, 4, 5, 6, and they're just in order here. And this is the length of service in days. So and this is example data. It's completely, there is no Josh and Sally. Those are my go-to names. Whenever I need an example name for some reason, I don't know why, I go with Josh and Sally, but I always do. So length of service here is 0, but that doesn't really mean that the cans happen on the first day, because a lot of times we get the data in the data reservoir. We don't really know when the kids entered care. So we always put that first assessment as 0. But if you were to donate your data de-identified and you wanted to include program start dates, that would be helpful too, because then we would know how long it was in care when they got their first assessment. But in any case, we set that to 0, and then we add and then we look at the date of the next assessment and say, oh, that was 120 days later, 245 days after the 0, et cetera. So we've got up to 550 days of assessments for Josh, 1 through 6. And for Sally, we have 4 assessments. So again, to show you this is not a balanced analysis. There aren't equal number of assessments. We're not going first to last. We're including every single assessment that we had. And then if you look at the first assessment Josh had, you can see he had high suicide risk, self-injurious behavior at a 3, sleep at a 2, depression at a 3. So here's his ratings across just a handful of items on assessment number 1. And then you can see assessment 2, the 3 went down to a 2 for suicide risk and self-injury across the board here. So you can see that change over time for those 6 assessments for Josh. Whoops. Sorry about that. And the same thing for Sally. So here's her assessment 1. She had high, she had a 2 for suicide risk, so she was selected. High 3 in sleep, anxiety, caregiver substance use, and caregiver empathy with child. Now, these caregiver items I put in here as example. You'll see these ones come up later, and that's why I use them in here for example. So I just pulled a handful of the CANS items. There were, was it 139, I think, CANS items in this particular jurisdiction's CANS. Is that right, Brian? It was around 139. Obviously, some of those were modules that may or may not have had responses. If the module didn't have response, we'd assume there was no issue there. Okay, so then the next step is to take the first 2 assessments for Josh and for Sally and for everybody in the group and look at what the first change was. So coming back to here, we're looking the change between just first and second assessment. So you can see suicide risk went from a 3 to a 2, self-injurious behavior went from a 3 to a 2, nothing resolved. So I did also want to say we converted this to binary. So it'll be a dichotomous scale. So it'll be a 2 or a 3 is an area of need, and a 0 or a 1 is an area of no need, or strength present or strength to build. So 2, 3 strength to build, 0, 1 strength present. So we dichotomize the data to reduce the dimensionality of the data. And so when you're doing an analysis, of this level of complexity, the first step is to how can we reduce dimensionality? How can we reduce the complexity of the data so that we can get a better model? And then in the end, maybe we can see if we can expand out to more detail and look at more of that detail. But can we start with the minimum amount of information and build a model that works, and then we can add more detail to it. So for Josh, there is no change from time 1 to time 2 if we think of those as dichotomous, 2, 3. For Sally, there is no change between time 1 and time 2 as well. So if we look, then the next step is look at, is there change between time 2 and time 3? And so you can see between time 2 and time 3, Josh resolved self-injurious behavior from an actionable need to not actionable. He also resolved anxiety, family stress, caregiver empathy with child, and some things came up actually. So if we look at Josh, and in my mind, when I was creating this data, I thought, oh, what if Josh changed placements at time 3? So that's kind of what I'm imagining is he was in one placement at time 1 and time 2, and a different placement in time 3. And so all of his caregiver things flip-flopped because he had a different placement and there was different caregiver kinds of needs. So that's a possibility I wanted to just raise in this data set, that the caregiver items may not necessarily always be the same caregiver, and we're taking the highest need of any caregiver so we reduced all the caregiver items down to the highest need of any one caregiver. Okay, so that's the first step, is to flag any item with a 1 that resolved between time 1 and time 2, and we're going to call that the first change, so the first resolution. Then we're going to do that for all the other times. So what we're going to do is we're going to look at all the different times that an item resolved, and we're going to build a data set that looks like this. So we had six assessments before, and now we have, instead of 6 assessments, we have 5 changes. The change between assessment 1 and 2 is the first change. The change between assessment 2 and 3 is the second. Between 3 and 4 is the third. 4 and 5 is the fourth, and 5 and 6 is the fifth. So these are the changes, and so you can see that we identified a 1 for anything that changed in the first assessment. Oh, I guess we did have a change in the first one, caregiver supervision. So let me go back and make sure that's correct. Oh, it didn't really change there. So that should have been a change, but it didn't change. So that should have been gone down to a 1, but so a little bit, so I might want to fix that for you so you don't get confused there. But in this example, we're saying caregiver supervision was resolved in between the first assessment and the second assessment for Josh. And between the second assessment and the third assessment, he resolved self-injurious behavior, anxiety, family stress, and cultural congruence. Between the third assessment and the second assessment and third assessment, no, third and fourth, whatever. The third change was sleep and depression. The fourth change, suicide risk, and the fifth change, caregiver physical health. So we've ordered all of the data with 1, 2s, 3s, and 4s and 5s for Josh. And for Sally, she's only going to have 1, 2s, and 3s. So she'll have 1, 2, and 3. In fact, that 2 should have been up there. But in any case, the next step then is to just consolidate that into one row. So we're looking across all of those. You can see suicide risk was the fourth change, happened in the fourth change. Self-injurious behavior resolved in the second change. Caregiver substance use never resolved, and it was never an issue. So that's going to be a 0 throughout. So this is now what we're looking at is the first resolution. So that's the other thing I should say is we're not looking at, in this example, if they resolved, it came actionable again and resolved it again, we're going to just look at the first time it resolved, thinking they were on the pathway to resolution, even if it maybe popped up again somewhere, they had been able to resolve it at least a first time. And so we're going to call that progress. And that's what we're going to look at, again, to reduce the dimensionality of the data. I agree that it would be of interest to look at things that do crop up again, and maybe in a future analysis, that would be possible. But we really want to reduce the complexity of the data for this first initial model building activity. So somebody asked, how can those risk behaviors reduce to a 0 when 1 indicates a history? Oh, well, this is fake data. So pretend it's a 1. So I was just making an example here. So I obviously made a few mistakes in my example, and that was a mistake that I made. Okay, so the other option that you could have done is we could have also used the length of service at the time it was resolved. And of course, the length of service, the time it resolved, isn't the actual time, like there wasn't like a switch that happened. It was the time that it was assessed that we realized that this was no longer an area of focus. And so instead of putting the 1, 2, 3, 4, and 5 in here, we can put the length of service. So 425 days. We found out suicide risk resolved at 425 days. We found that self-injurious behavior had resolved at 245 days in care. So this would be another way to organize that data that would be equally as appropriate. And a little bit more informative, because now you have kind of some sort of proxy for length in care when that was resolved. Okay, so then the next thing we did was identify items that were more likely to change before other items. So in this case here, we're seeing that, suicide risk is one of the last things to resolve for Josh, but is that the case for everybody? Like what resolves more commonly before suicide risk? And then if that resolves, is there something that resolves more commonly before that? Like, what does that trajectory look like? What resolves first, second, third, fourth, and last? And at this point, we're not really contextualizing it into their story. We're just simply saying, if something resolved, does it impact another area? Does it open up the floodgates for another area to resolve? And we're not going to contextualize in their story at this point, because again, just reducing kind of the complexity of this first model. So to look at whether one item resolved for another, we created this differential. And the differential basically says things could resolve at the same time. So because we're only assessing every so often, and if things are kind of really closely linked, for example, we found that in substance use, peer influences and environmental influences are really super closely correlated. And when peer influences resolve, environmental influences resolve, and vice versa. And those resolve together almost all the time. So those ones are same time. They're gonna happen at the same time almost always because they're really closely linked. And by the time you reassess, they both resolve. And so that's going to be kind of a same time, highly same time. But then some items are actionable more often than others. So in this example, item 2 tends to be actionable more often. Item 2 tends to be more actionable than item 1. So for our population of 1,000 kiddos, for example, we're going to say 500 of those kiddos had item 2 as actionable, but only 200 had item 1 actionable. So we need to accommodate for the fact that some items are just more prevalent in the population. So then we look at how often when item 1 resolves, does it resolve before, at the same time, or after item 2? And then we create a differential on that. So percent of it resolved either at the same time or before is 45% in this example. And the percent of time that item 2 resolved at the same time or before item 1 is 12%. So the differential now is 33%, meaning that item 1 tends to resolve before item 2. So that's that differential there. It's like just identifying, does item 1 tend to resolve in our population before or after or at the same time as item 2? And in this case, it's before. So that's just kind of in the weeds there about how to create those differentials. So when you do that, and you do that for everything, you get something like this. So this is a little heat map of those differentials with suicide risk kind of expanded, so you can see it here. And everything on the suicide risk, I'll tell you right now, resolves last for most kids. Or not last, but after many other things. So the green here, these numbers are going to be the same. It's like a correlation matrix. So they're going to be the same on the vertical as they are on horizontal, except in the negative, right? So what this is saying is that delinquent behavior resolves before suicide risk, and that adjustment to trauma resolves before suicide risk. And the same thing over here, suicide risk is resolving after all of these other items. So we're finding and with these complex behaviors that we're picking, and we would expect this, they're not going to be the first thing that resolves. We're finding that there's other things that tend to resolve before them. And by these differentials, we're able to see, for example, there are things that resolve before them very, very often, like affect dysregulation has a really high differential to resolve, and substance use here, substance use and affect dysregulation resolve before suicide risk resolves. And so that's what this is saying here. So we take these, and then, I did a scree plot to say, okay, here's the differentials, and there's an equal negative on reciprocal on the other side. But is there any kind of cut point? We ended up doing Z-scores to make cut points. And so we identified what was the average. We created a Z-score of the differentials and identified, 1.96 above or below the average to get that kind of 5% tail ends, and just stick with that for the analysis. So we looked at where that cut point was and identified things that were around that cut point and said, okay, so this is the same as this, but now I've just whited out everything that didn't meet those cut points. So the positive and the negatives are going to be the same, just as a correlation matrix. And then I ordered it by suicide risk. So you can see the top thing is fire setting. Almost always resolves before suicide risk, sexual aggression, psychosis, sleep, etc. So these are the items that are resolving more often before suicide risk. Oops, sorry about that. And then, in the negative, it's just easier to see along this as well to see any of those relationships. If we look,
there's a couple questions in the chat that you may want to address, and it's just a couple methods questions.
Yeah. And then so I may have missed the part where you said, how did you determine what was resolved in first, second, else? Oh, okay. So that was back in the example of the data here. So here is the example raw data set. So we're looking at, for example, self-injurious behavior resolves at time 3 on his assessment. And let's see. Suicide risk resolves at time 5. So self-injurious behavior in this case is resolving before suicide risk. Does that help answer the question? And so we're marking this as a 3 and this is a 5, and we're identifying that it's self-injurious behavior is resolving before suicide risk. And we're finding that that does hold across the whole population. So this is just one example, kiddo, to show you how to prepare the data. And then we're finding here that does hold across the data, that self-injurious behavior, which I apologize for the tiny writing, but you have access to these slides to take a closer look. But self-injurious behavior is in the middle here, and it is often resolving before suicide risk. But if we look over here, what this is telling me is that running away behavior, actually, I think I may be up here, so that running away behavior has to resolve before self-injurious behavior. So it's the order is run away, then self-injurious, then suicide risk. So from this model, it takes a little while, but you can build out this ugly diagram. And this ugly diagram says, here's those things that were associated and must be resolved before suicide risk, or not must be, that tend to be resolved before suicide risk, but what resolves before them? So you just put them all on a piece of paper and draw arrows between it based on those differentials. And what you can then identify is this. So I pulled from this example a pattern of interest. So there's lots of patterns in here that you could pull, but I was focusing on this cultural congruence one that seems to be affecting a lot of things downstream. And then pulled that relationship out of the rest and pulled with it only things that were associated with cultural congruence and suicide risk. And so what this map, and it's kind of like a DAG, shows is that in this case, there was a question on the cans asking about the child placed in foster care if they had a congruent cultural belief system or value system to the foster care family. And when it was a 2 or 3, it was actionable. And when it was 0 or 1, it wasn't in our analysis. And what this is showing is when cultural congruence is actionable, that it resolves prior to these other areas. It will resolve prior to caregiver substance use, prior to caregiver supervision, and prior to suicide risk. And that cultural congruence will resolve prior to caregiver development, prior to family stress, prior to empathy with child, self-injurious behavior, supervision, and then prior to suicide risk. So what this is saying, and this is only descriptive at this point, what this is suggesting as a hypothesis formulating activity, and that's what I would say we're doing right now, is we're building patterns of interest as hypothesis formulating activities that we would then test later to see if they hold true in a controlled analysis. But in this hypothesis forming activity, the hypothesis here is that when a kid is not placed in a home that has cultural congruence to the child, between the child and the family, then there's going to be a lot of downstream need that won't be resolved until that cultural congruence is resolved. And that could, if it's related to caregiver, if self-injurious behavior is present and caregiver development is present, and actually cultural congruence does directly relate to self-injurious behavior as well. If there's cultural incongruence and self-injurious behavior, if you're targeting that self-injurious behavior in care, you should also be targeting the congruence, the cultural congruence. So I'll just pause here before we move on to the substance use and just, open it up for discussion.
I just really think this is a promising pathway to take things. I think it has all sorts of potential implications as it gets fleshed out and so forth. Like I was sitting there thinking, if you repeated these analyses with moving from 3 to 2 on suicide, and you found that even moving from 3 to 2 is the last thing that happens, it calls to question the value of a psychiatric hospitalization for acute suicidality, because it's not going to work, right? It's just a period of days where you're taking a kid out of their community and maybe they don't do anything, but it's not likely to have any impact on their suicidality because other things have to change before you're going to be successful. And hospitals don't do a very good job of treatment, and they disrupt actually ongoing treatment. So I think there's the potential for all sorts of interesting implications for these kinds of things. That's just one of 1,000, but also find the cultural congruence one really important and interesting. And I think what you're seeing in the particular state with this is not only African American and white, but also tribal and non-tribal distinctions. And I think those are really important to understand in child welfare contexts and their importance. So I might even go a little bolder than you, Kate, and say maybe if this stuff holds up and with hypothesis testing and so forth, you're really saying your first job is to make the culture fit. And that if you want other things to fall into place, you kind of expect that to happen first as a kind of your first priority. It also, the other thing I was saying about suicide is, why on earth would you put the resolution of suicide risk as your goal in your very first treatment plan? You're setting the kid up for failure, right? Because that's not actually how this stuff works. And so maybe we should pick our goals a little bit more congruent with an understanding of how people actually change. And that's another implication of this kind of stuff. So I'm thrilled about this. So I got to say, as I was trained as a statistician, but when I hang out, I call them the ladies of precision analytics, 3 really smart women. I think they're really doing some spectacular work. So good job.
Oh, thank you. Thank you. And we're going to rely on Olga to figure out how to test this. Right. But we're challenged at the moment to figure out the right model to actually test this hypothesis. So we've generated the hypothesis, and I think we can open it up for discussion today and onward. Feel free to email any of us on we've created the DAG, so it would make sense that you would want to do some sort of causal analysis perhaps, or we were looking at path analysis and did an attempt at path analysis here, which I think may be correct. We're having a little bit of problem with when things don't resolve, how to code those, and that's messing up our model. So we haven't really gotten to the point where we can test the hypothesis. There are other hypotheses that were generated from this little diagram here that you could pull out that had to do with runaway behavior, caregiver physical health, and some other things. But this was one of interest that I pulled out to just say, this is a method to look at what are the patterns in the data that exist in your population, so you can begin formulating those hypotheses, testing them, and then informing the way that you provide care or prioritize care. Okay, so we have Amanda saying, I really like that it is referred to as cultural congruence. Where we are at is termed cultural stress as a need, not a strength. Would love to see New Jersey move this direction to include congruence. Thanks, Amanda. Great. Yeah, it was super interesting. I thought that this is what came out in that, at the top of the tree here, placement is so important. And FaithBridge, that I'll be presenting with on Thursday, are using the cans to and we'll show you in the family reports on Thursday how they're using the cans to make good placements in foster care. So that might be of interest as well.
And I think this issue and discussion of culture and cultural congruence is really crucial, especially for other kinds of populations like the LGBTQ plus population, in whom we know that there are increased rates of suicide risk, increased rates of substance use. And I think that kind of broader discussion about really being responsive to kids' cultural needs at the outset as a protective factor and as a resilience building technique, even when we are in this place of kind of tertiary prevention, they're already with us in the system, but doing that as a really early intervention, I think, is crucial for all kinds of populations for kids.
Yeah, excellent. Yeah, I definitely think a paper could come out of this if we could, get to the end goal and find that these relationships hold. A very impactful paper, perhaps. So that's as far as we got with the suicide risk. Same thing with substance use. So let's just look at that. Again, apologies for the deep in the weeds piece here, but some folks hopefully might find this interesting. These are the differentials, again, with the expanded, this time in substance use on both, again, like a correlation matrix where there's zero differential between substance use in itself, but that it is resolving last most of the time. And there are many things that are resolving before it. Expression of distress being one of them in this particular case. So then if we kind of white away the noise and look at just the differentials of interest, this time I'm showing the actual z-scores rather than the differentials. So converted these to the z-scores, and so you can see above or below the mean of 2 or more here. So you can see substance use is resolving after caregiver organization, child vocational, relationship permanence, community safety, optimism being built, social functioning for adults, family stress, history, talents, and interests being built. So you see some strength showing up here, which is super interesting as well. And if we pull that relationship out, it's a little flatter. But one thing you'll find, and again, this is the same population, but a slightly different set of kiddos, as you can see by their age groups. There could be an overlap between substance use and suicide, but it's not all the same kids. But cultural congruence comes out again on top when the kid's not placed in a family where they have a cultural congruence. Then there's family stress. There's perhaps a concern with empathy for the child, and that is related to substance use. And if you're not resolving, if this resolves first, then family stress and empathy with child is likely to resolve, and then perhaps substance use. Of course, it doesn't all happen on its own. It's part and parcel of the great work of many of the folks on the phone today in the care planning and the work of their staff, clinicians, and social workers. But you don't want to go straight, as Dr. Lyons mentioned, you don't want to go straight to saying, okay, the first thing we got to do is that substance use. You got to first look at, let's see about their optimism, their environmental influences, their expression of distress, their anxiety, their self-injurious behavior, talents and interests, intentional misbehavior, relationship permanence, and their vocational. Those are other areas that are associated with substance use or resolve prior, on average, to substance use.
Kate, this is Barbara. I have a question. Mm-hmm. So if there is a youth with substance use, but the cultural congruence is not actionable, does the rest of this still hold? Or do we? Okay, thank you.
Yes. Yep, absolutely. And so thank you for that question. That was what I was imagining, is that you could overlay the story map onto these networks and drop away anything that doesn't match the story map and just leave present the things that do. And this would make this a lot less complicated. So if you have a kid just with anxiety, a need to build talents and interests, and maybe relationship permanence, those are the areas you're focusing on in order to then downstream address substance use. In theory, if it holds after formal testing.
Thank you.
Yeah, great question.
Not to mention, though, Kate, it is the case that each relationship between each of the different needs and strengths are just those two relationships, right? Just those two variables for each of the different nodes in the analysis. Yes. So in theory, it should be possible to just drop things out of the model when they're not relevant, because the Correct. Relationships are stable regardless of whether there's some other need or not.
Correct. I think we had a couple comments. As a provider who was attending the TCOM conference for the first time, I'm curious about the systems in place to get the results of research to providers. It's a good question. I don't know if Dr. Lyons, you have a thought on that?
Well, I'm glad you've come to the conference, because that's currently our best way. So this is a really, I'm glad you asked that question, because it's a really, really fundamental issue. So figuring out how to create translatable use of data to give back to people is a major focus of what we're trying to now accomplish. I mean, we've spent probably the first 15 years of this trying to get people to actually do the damn tools, right? And so now people sort of do it, and some people actually use it. And so there's been this positive evolution that people understanding that information is good, and if you create information that's meaningful, you can actually use it, and all that's good. So that trajectory has been pretty stable. And I think at this point we have more people using it than doing it, but that's always an impact of the implementation maturity. Now using the data is the next stage. And so when we first started working, most EHRs and data systems, they were all about data entry. And, most SACWIS systems, the first SACWIS system I worked with, you couldn't get any data back out. And so there are some major obstacles to just even getting the data. Over the last 10 years, most of those, and then there's new platforms like Opeka that have been developed that are really very interactive with the data, and I think that's extremely valuable. But that's the kind of the new big thing, is how do you actually do that, and how do you give people useful information, and then how do you take things that are done for research and get it out into the field. So we're going to try something. I don't know if it will help. So you can tell us next year whether it was any value. So we're trying to get researchers to work with us. So you'll see tomorrow, you're going to see, if you haven't seen it already, the YouTube channel. And we're putting out regular brief videos. There's going to be a different one each week. One of the weeks is the heuristic of the month. So you'll see that tomorrow. We want you to view it and like it, because we're trying to get the word out. And then, in our current zeitgeist, the word out is in social media. So view it and like it. And that's just spreading the word about how you think about this approach. Or we've also asked researchers to work with us to create similar kind of little videos, short little videos, because the average person now has the attention span of a gnat, right? And so you have to do it in quick, short, brief things. And so like 3 to 5 minutes is all, and just do a little, this is what it is. So we're going to try that with the transportation paper that Olga and Elizabeth worked on, that Kate referenced, where we found that unmet transportation needs predict clinical and functional outcomes with kids. And if you move to telehealth, it eliminates the impact of unmet transportation needs. Go figure, right? So anyway, those kind of little brief things, getting them out there. But if you have additional ideas of how to improve the uptake of research, that would be greatly appreciated. Now, I will be honest with you, we do have a subtle another way that we don't really talk about, but is absolutely true. We design the tools based on research. And so we will add items or change items based on research and not tell anybody that they're based on research. We'll just do it in the context of the evolving nature of the tool. So if you think about what the tool actually is, it's actually a translation of what we know from research into an assessment practice model. So there is that underlying quiet revolution kind of part of this approach that is fully research-based, but we don't really talk about it in that way because of the complexity of that kind of dialogue. So that makes sense. Does anybody have any other ideas? What can we do to help people read research and keep up to date and make it timely and active and so forth? Well, that's interesting. That makes sense, Barbara. So Barbara says that they found unmet transportation need as a proxy for poverty. Yeah, I mean, that's a social determinant, right? So, and most social determinants have an overarching concept of poverty, and most poverty has an overarching concept of poor or failed education, right? So they kind of build on each other. I mean, one of the things I think that we're going to increasingly find as we do more research is the ultimate solution to some of our challenges are not within our sector. They're in other sectors, in the education sector and in the community development sector and in the professional career vocational development sector, and that those things are turns out to have profoundly important health and mental health implications and child welfare implications as well. I think that's where we're headed in terms of what the research is beginning.
Yeah, also we're open to questions now. So we're at the discussion period as well. So any questions or how to get the word out? And then there's a few comments in the chat I'll read in a minute.
I do have one question. So the data reservoir, is there a group that meets about the data reservoir? And so is that one of the ways that the information gets out? You participate and that's how that information gets spread?
Yes. Yes. So that's true. So there's a couple of different aspects of the data reservoir, and it's sort of in construction as we speak. So there's a data governance group, and that's a group that has a representation of states, of universities. We have a lawyer on it that some of you might know. We have a parent representation, and we have what did I say, university? So a provider. So provider, state, university, lawyer, service, somebody with lived experience kind of perspective. And so that group oversees the ethics, I suppose, of the structure and function, and making sure we're doing things in the best interest of the greater world. But we're probably going to use, at least initially, the university collaborative mechanism for trying to use that to stimulate research. But we think that is likely limiting, and that there are going to be folks like yourself, Barbara, that are not university based, but do have, an interest in using research. And so we want to figure out how to make that as accessible as possible. If you have any ideas on how to do that, that'd be great. So we have these collaboratives. We have a child welfare collaborative where we think we can actually use the child welfare collaborative and then give them data. Mm-hmm. That kind of stuff. I think that's how we're trying to think about it. It's going to pull people together and just build what we find in the conversation. So when I was young, somebody who ended up being my career mentor, a guy named Ken Howard, who was if anybody was, he was the founder of Outcomes Management. Anyway, I went to a talk that he gave, and he said, don't give anybody a report. Nobody reads reports. They're just a waste of time. What you do is you walk around and you talk to people, and you drop little nuggets of findings, and you get them to think about it, and then you follow up with a conversation. If they need a report just to put that in their files that they have a report, you can do it, but that's not actually how information gets transmitted. It's not how information gets encoded in people's thinking, and it's not really how this works. Now, I think that might be too cynical, but I'm not sure that it's wrong, that we have to kind of come up with ways of communicating things in digestible bites that gets people thinking and talking. And I think that's actually how we kind of make this work. So we're trying to figure out different ways to create forums for people thinking and talking and sharing. So if you went to the trainer booster, you'd see Rob and Orlando saying, steal shamelessly, share relentlessly, right? So that's sort of that could easily be the motto of our approach, So borrow from everybody else and share it widely.
Well, the TCOM blog, that has gotten some traction, maybe.
Yeah. So TCOM blog and the YouTube channel. So the blog gets about, so the Parade Foundation gets the most views. We get about 13,000 visits a month. The blog is now up to about 3,000. And the YouTube channel is up to about 1,000, but the YouTube channel is brand new. So we think that if we have these kind of multiple strategies, that's probably the best way. We're going to start a podcast as well to kind of look at it from a more humanistic perspective, individual stories of change. So I think the more different ways we can kind of find to talk to people. If you think about TCOM implementations, everybody can get on the bus, but different people get on the bus for different reasons at different times. And that's why it takes kind of this long and staggering actually implementation process, because it just takes a while for everybody to say, oh yeah, okay, I'm actually willing to throw in my lot to working together on behalf of people. And I do believe that a common assessment strategy is one way to work towards achieving that. So I'll try my best and participate.
Folks like the podcast idea.
I want to back up to, I think it was Sharon. Cheryl. Let me see if I can find it. There's almost there. It is Sharon Campbell talked about costs. I do think, Sharon, that you're right, that we need to find ways to integrate clinical and functional information with service delivery and utilization information. I'm really skeptical of doing research that says you can save money by spending money, because I've never once met any legislator who is willing to do that. That they're happy to spend money if they look good, and they're happy to save money. But I've never seen them convinced that if they spend X number of dollars, they'll save. This is why prevention, we need to rethink that and repackage it and rebrand it, because it's not a winning argument. Because as soon as you've successfully prevented something from happening, you get your funding pulled because there's no need for that investment. So anyway, so I think it's challenging to make the argument, but I think the argument of embedding this into costs, and what we invariably find with the decision models is that if you do things on behalf of kids, your system is more efficient and therefore less expensive, because the system tends to overserve the people who are willing and underserve the people that they don't get. And so figuring out how to right size the system, so pulling more people in that are otherwise not served, and then figuring out how to encourage the right level of intensive intervention.
And just to read out some of the other comments of suggestions: popular social media, Instagram, post-conference, if there could be learning collaboratives throughout the year by topic of interest on a regular basis. And then I'll come back to the other side. And then TikTok, podcasts were very popular. TCOM CAN's Facebook or Instagram page, daily posts to follow.
Something that we're also working on that I think we're pretty excited about is creating what are hopefully going to be pretty digestible research briefs or versions of the papers that are coming out of our center that are kind of like one-pagers that are really designed not to be research heavy. They're designed for clinicians, for administrators, for people who want to use that information, but in a much more digestible format.
Do you have your draft of that?
I do, actually.
On the screen.
I can share it. I just pulled it up. I just found it. Let me.
As soon as I can figure out how to stop sharing,
you stop sharing yours. Yeah.
Good luck.
That's always the issue. Okay. All right. Let me pull it up real quick. And this is still in its draft form.
She's pulling that up, I'll just address some of the other comments that came up. So Samantha was talking about, as a clinician, all of these statistics are a bit overwhelming. 2 to 3 bullet takeaways can help. Oops, and I lost my comments. They disappeared with the sharing. But yeah, absolutely. And and my disclaimer, my apologies too. I knew we were going to get in the weeds a bit. But hopefully there was enough of variety here that's something for everybody. But I agree, I think once we get to the point where we can take away from this, at this point, we're hypothesis generating. So unfortunately, I don't want to send any take-home messages, except my only take-home message would be try this with your own data. And I've given you the whole blueprint to do that so that you can see what patterns exist. And then we can have ongoing communication on how to test those patterns. And then we can take those 2 to 3 bullet points away. But I would say for today, the 2 to 3 bullet points is, there is an order of resolution that would be helpful to be aware of for care planning, but what that order looks like in your population is yet to be discovered. And then, go ahead, Elizabeth. Thank you.
So this is just an example. Yeah, I think that was great, Kate. This is just an example from the paper that Olga actually popped into the chat earlier in the meeting. When we're doing a poster session on this later today, if you're interested, I'm happy to talk more about this kind of research. And Olga has a poster that's kind of the follow-up from this paper. But this is the idea that it's really going to be sort of a straightforward version of the paper that's published. This is still in its draft form because the paper is still in the publication process, but we got just kind of understanding why the research topic was important, a really brief little piece about what we did and why we did it. So we used the cans in this paper, and then, you know, a 5-sentence section on the hours and hours of work that Olga did on this analysis right here, and then a couple bullet points about the results. So, you know, for this transportation paper, what they were, what the major results were, and then here at the bottom, kind of a policy impact. So what's really, you know, not just the take-home message of the paper itself, but what does it imply? What does it mean? And so these are the kinds of things that we're hoping to create for all the research that comes out of the work that we're doing. And I would envision that these kinds of things would be put on the blog or on the website, or, you know, things like that to try to be disseminated. And then, you know, for people who are interested in more of the research, we have the link to the actual paper there. So,
and we would invite anybody who's doing research that we were happy to help you put things into this format, and
absolutely,
then we're happy to use our distribution networks to get it out there.
Absolutely.
I mean, I think most researchers will be sadly shocked that you get more uptake from a blog post than you do from a journal article. So, I mean, the cans actually got its original uptake not from any of the tens of publications that I managed to get done, but from one mention in a throwaway newsletter put out by the Robert Johnson Foundation for their system of care work called MISFI, and they just mentioned it, and then boom, it suddenly became something, right? So, I mean, the truth of science even is science moves through social media faster than it does through regular science.
Excellent job. Can you all hear me?
Mm-hmm. Yes.
Excellent. So we are at the top of the hour. If you could please give a physical or digital round of applause for our presenters today, Kate, Elizabeth, as well as Olga, and some background dancing from Brian and John. Really appreciate it. Thank you for attending Successful Trajectories of Resilience for Youth at Risk, Dangers to Self and Dangers to Others.